Okay, so welcome back. We're going to move on and discuss domestic abuse and elder abuse. So there are two videos that I have posted on Blackboard that I would like you to watch and review. One is called Monsters in the Closet, and this is regarding domestic violence from a child's perspective. The other one that I would like you to watch is What Would You Do? And what I find most compelling about that video is how many people did not help this woman when she needed help. So please review those two videos to give you a perspective on these two topics, on this domestic abuse topic. So what we do know about domestic abuse is that it occurs in families of all socioeconomic, religious, cultural, and educational backgrounds. So again, it is an equal opportunity problem. 25% of all the cases occur with an intimate partner who is not married. So it's not just a married couple's problem. It can happen with any intimate partner that a person may have. Violence is the abuser's pattern. It's not really about anything to do with it's mostly to do, their behavior pattern is all about having control. The abuse tends to get worse when the abused person threatens to leave or divorce the abuser. And this is because the abuser feels even more so that he's losing control. He or she is losing control, and therefore the abuse gets worse. Abuse, we have learned, is a learned behavior. It's not an uncontrollable reaction. It is controllable by the abuser, but it is a learned behavior. So what that means is people who are typically abused, or if they have witnessed abuse, they get this mentality, or they acquire this belief that violence and aggression are acceptable behaviors, and therefore it's a learned response. It frequently begins or escalates during pregnancy, and this tends to be because the person who is abusing is losing control again. The pregnant woman may be getting a lot of attention regarding the pregnancy, maybe getting special treatment, and the abuser tends to get jealous of all this attention and has this desire to control the situation, and therefore the abuse gets worse. So characteristics of abuse, characteristics of violent families, I should say. It is a multi-generational transmission, and again, that's probably because of the learned behavior that they have observed or participated in. It's passed down from parent to child to child, or a child to parent, as we'll discuss when we get into elder abuse. Another typical trait is that there is social isolation. So the abuser tends to isolate the spouse from others in an attempt to keep family secrets. And I think you know what I mean by that. Alcohol and drug abuse play a huge role in abuse, and they use this as a socially acceptable explanation for their abuse, so they can easily say, well, I was drunk when I did that. Okay. We have found that children who witness domestic violence between the parents or perhaps the caretaker, it has the strongest risk of transmitting violent behavior themselves later in life. It's been found that boys who witness domestic violence are twice as likely to abuse their own partners or children when they become adults. 30 to 60% of perpetrators, that's the abuser, of an intimate partner also abuse their children in the relationship. So in Wausau, there is a called the Wausau Community Center. This is a crisis center where anybody who is uh, um, having problems with abuse, it can be the child, it can be the person being abused, can go to this crisis center and get protection from the abuser. Okay, every county has such a crisis center. It just so happens that the one in Wausau is called the Women's Community. Now, it doesn't mean that only women can go there or children can go there, but if a man is being abused by another man who is his partner, or perhaps by the woman who is his partner, they also can go to the women's community to seek refuge. So what are some environment and internal stressors that cause domestic abuse? Well, some social factors that reinforce violence is this wide acceptance that our society has on corporal punishment. Some states, do continue to have the death penalty, which gives the message that abuse or violence is acceptable behavior. We increasingly have violent movies and TV shows that are on television. I can think back to when I was a child, and half of the stuff that is on public television now in the evenings is would never have been seen in my time. It was socially inappropriate. But our social constraints have been laxed so much that now this is common practice for our children to be seeing violence, sex, and other things on our television shows. Violent video games, as you know, are becoming quite acceptable. Graphic. I mean, I have watched my kids play these games, and they're like war games, and they are graphic with blood and shooting off heads and everything. So even the simple video games, websites, comic books, all have this violent theme. That is reinforcing for our children that aggression and violence is okay. We are seeing increased pornography, child pornography, and just pornography in general. And we know statistically that pornography is strongly associated with physical abuse of women. So the perpetrator, the perpetrator who initiate violence often consider their own needs before anybody else's. So it's all about them. And they look towards others to meet their needs. So if they're frustrated or they're angry, they will use other people to take those frustrations out on. Often the abuser has lacked good role models and was deprived the opportunity to develop any appropriate problem-solving skills. Behaviors and characteristics of perpetrators typically are jealous or controlling people. They have unrealistic expectations. They blame others for their problems. Remember, projection. They're hypersensitive and perhaps cruel to animals. They're verbally abusive, or they take a rigid sexual role in the relationship. They may have a Jekyll and Hyde kind of personality where they're real sweet and then they're like the devil. Past history of battering or threats of violence is a good indicator. Breaking things, throwing things, or striking things is a definite risk factor. Using force during an argument, maybe pushing, and constantly checking or having checking on the partner, just like checking their phone all the time or following them around when they go places, just having this insecurity and feeling that they need to monitor their partner at all times. Okay. So vulnerable people, we've been talking kind of all along about vulnerable persons, and it can happen to men. It's statistically shown to happen more often in women. Family members can be abused, as in with elder abuse, usually there is some type of weakness that the person is exhibiting that makes them vulnerable to being abused. So for women, it might be that they're dependent on the abuser, or the pregnancy again could trigger some abuse. Um, Children, just being children makes them vulnerable. If people have cognitive abnormalities or chronic diseases that make them weaker, makes them vulnerable to be abused. Um, Older adults, again, if they have any cognitive disabilities that require them to live with a relative or are physically or mentally impaired, predispose them to being vulnerable for abuse. So the cycle of violence has 3 phases, and it's really a pattern of leaving and returning, if you can think of it that way. Typically, the victim will return to an abusive situation 7 times before they eventually leave for good. So the 3 phases are tension building, battering, and honeymoon. So we're going to talk a little bit about each of these phases. So phase number 1 is the purple area, okay? This is considered the tension building phase of the cycle. The abuser starts to get angry, abuse may begin, the victim feels like they're walking on eggshells. It's just this tension building. They feel like they need to calm the abuser down. Tension becomes to be too much, and there's a breakdown in communication, so they just stop talking to each other. Phase 2 is the abusive incident. It's actually when the abuse occurs. So the abuser is typically unpredictable. They lose their temper. They are highly abusive and participate in an incident of abuse. Then they typically blame the victim for their behavior. The victim during this phase is traumatized, helpless, and basically just feels trapped. Phase 3, you'll see, is in the yellow area here. This phase is what I call the makeup phase. The abuser typically feels bad, or they feel threatened that the victim is going to leave, so they may apologize for their abuse. They may make excuses for it. They may make promises that it'll never happen again. They may blame the victim for causing the abuse, putting that guilt on the victim. And then they're going to be manipulative. They may deny that the abuse took place, say it wasn't that bad, things like that. Now the victim during this phase is really kind of all mixed up. The victim feels guilty and responsible. They have a lot of mixed emotions. They are considering reconciliation. You know, they want to believe that the abuser isn't going to do it again. And they themselves will minimize the abuse and believe that perhaps this really is the end. So what this slide depicts for you is just all of the techniques that the abuser uses against the victim, okay? And oftentimes some key things is that they try and isolate the person. Remember that family secret, right? So they may deny the victim access to church or clergy. They may deny the victim from going out and working. They may control all the finances to try and control the person. They may cut ties with their family members. And they do this by magnifying disagreements in the family or misleading family members about what's going on, or exclude or deny the family access to the victim. They try and isolate again. This is a control technique, so what nobody can see, nobody knows. Limit times that they're with family and friends, deny the victim any phone or mail, email access, or cell phone use to try and isolate that person. They may even go so far as to moving the whole family to out in the country or far away from any friends and family members to try and isolate the situation. So the violence typically revolves around three categories: physical abuse, sexual abuse, and emotional abuse. And oftentimes there can be a combination or all three of these types of abuse going on. Physical is pretty self-evident. That would be slapping, hitting, maybe burning the victim, choking, or throwing things at the victim, okay? Sexual, it doesn't have to be that they are raping, but that is part of it. But sexual abuse can include demeaning remarks about body parts, being rough with the person's body parts, taking advantage of physical or mental illness that the victim might have, and to engage in sex, forcing sex on the person, or forcing the person to watch pornography. Those would all be examples of sexual abuse. Now, emotional abuse, that would be like humiliating, demeaning, yelling, degrading, blaming them for the abuse, withholding affection, giving them the silent treatment, or just plain old insulting them. And again, we can have all three. We can have each separately or a combination. So what is the nurse's role when it comes to domestic violence? Again, we need to examine ourselves. We need to do a self-reflection. How aware are we of our own emotional and judgments and thoughts? Our strong feelings about the abuser or our anger towards the abuser is not going to help the victim in the end, okay? Strong negative feelings can cloud our judgment and interfere with our objectivity in helping the victim. So we have to first do that self-examination. Primary prevention, really our goals here are to take measures to prevent any further abuse from occurring. So we want to identify individuals that are at high risk. We want to be providing them health teaching and coordinating support services for these people to prevent them from getting into a crisis. All acute care facilities now, we all have to ask the patients if they feel safe when we are doing our initial assessment with them. We have to ask them if they feel stressed or unsafe in their homes. So strategies that we can use to help the victims is to help them reduce stress, help them reduce the influences of these risk factors that we've talked about, increase their social support network, increase their coping skills, increase their self-esteem. They have, especially if there's emotional abuse going on, they have a very poor sense of self. Building that and assertiveness will help them. Um, uh, what's the word? Not referring, but encouraging them to participate in therapy, which will even further help them deal with some, or help them build some coping strategies. So in primary prevention, really our biggest goal is to build that trust with that victim, so that they know they can come back to us and that we are somebody safe, and we are going to help give them the tools that they need to overcome this abusive situation. Secondary prevention, early intervention in abusive situations to minimize any disabling or long-term effects, okay? Again, building that trust and rapport with the patient and focusing on the details of the violent experience. This is absolutely crucial. And we want to advocate, give them the tools that they need, and empower them to leave the situation. So we use an acronym called RADAR to try and remind ourselves what we should be discussing with our patients when we're doing an assessment. So the R is that we need to remember to ask. We have to ask if there are any safety concerns, and ask if they feel safe. We need to be asking directly, are you afraid? Do you feel safe? We need to document every incident, document anything, any data, any statements, use quotes from the victim, but we need to gather that data so that if the woman decides, or the man, I should say, decides that they are going to press charges or they're going to do something about the abuse, that we have not dropped the ball by not recording the critical information that they need to pursue this. Okay, we need to assess the client's safety. Is it safe at that point for that person to go home, or do we need to assist them in getting into a crisis center? R is to review all the options that the victim has. And one thing that we want to make sure that we're discussing with them is their safety plan. And what this means is, do they have important phone numbers, police lines, crisis hotlines, phone numbers of friends or local shelters or people that they can rely on? Do they have those phone numbers handy? Do they have a good relationship with friends that are nearby, or perhaps a neighbor, excuse me, that they could confide in regarding the abuse, and maybe, have them watching out for the victim, and if they hear anything or suspect there's any violence going on, to be calling the police for them. Have them practice ways to get out of the house safely. Having them, plan their escape route is very important. If possible, advising them to locate all the weapons in the house and get rid of them. Think about places where they could go if they needed to escape. Could they run to the neighbors? Could they go to their friend? Is there a family member that could come and pick them up quickly? They need a safety route. And then go over the safety plan regularly. And if there are children involved in the family and are in the abusive situation, the victim needs to make sure that the children are on board with what the safety plan is. So if they are planning on leaving the abuser, they should have identified at least 4 places that they could go. They should always have a bag ready and hidden somewhere in the house. Again, they should have identified people who would be willing to help them. Okay? Make plans for pets. Oftentimes, they have some cherished pet. So they should have a plan for that pet. Are they going to take it with them? What are they going to do? Are they going to drop it off at the neighbor's? Or are they just going to leave it there? Okay? Bank accounts. They should keep a small amount of cash available, but it's not feasible for them to try and squirrel away large amounts of money. That's just not going to happen. Remember, the abuser controls the finances, and typically the victim does not have access to any of those finances. But if they could have just like $20 on them, something that, in an emergency they had some money if they needed to buy food or something. Again, think about how they will escape. Will they take off while they're taking the trash out? Will they take off when they're out walking the dog? Will they do it when they're going out to do the grocery shopping? What's their plan for escape? How about the children? How are they going to maintain the children's safety? Again, making sure that the children are aware of the plan. Maybe they make up a code word so that when it's time to go, the mother just has to say done, or some code word where the children would know, okay, we're leaving. Okay? And again, there's always that woman's community center or other crisis centers in which they could go to. So what is our responsibility as nurses when it comes to reporting domestic violence? In the end, if the victim is 18 years of age or older, they are an adult. So therefore, they have the choice. We cannot force them to report or not report. It's up to them, okay? So the only time that we as nurses would report abuse, a domestic abuse, would be if the victim agrees to report, or there are some extreme circumstances, such as a gunshot wound, or if the victim is mentally compromised, or if the wounds are so extreme that you know, it was almost excuse me, it was almost life threatening. The injuries are life threatening, so it would almost be like a homicide attempt. If they have second or third degree burns over 5% of their body. So it would have to be a really, really, really extreme injury for us to, without consent, report domestic abuse. So what are the long-term and short-term effects of abuse? We know that there are higher incidences of depression, anxiety, suicide attempts, self-esteem issues, inability to trust others, inability to develop relationships, antisocial kind of behaviors, and also incidences of post-traumatic stress disorder, to name a few. Reoccurring symptoms that may take place are flashbacks. The person may disassociate, and what that means is disassociation is one of those coping mechanisms, right, where either they don't remember the incidences or they block out the traumatic event. These victims may have compulsive or impulsive behaviors, such as substance abuse or excessive spending, things like that. And they may have just this myriad of somatic complaints. And what that means is just vague complaints. They just don't feel good, or they have aches and pains all over their body all the time. Just complaints like that. What we know about children is that they typically will exhibit regressive kind of behaviors. So if they were progressing developmentally normally and then there is some abuse going on, you'll see them regress to wetting the bed or wetting their pants or sucking their thumbs, regressive behaviors like that. Adolescence, some cues for things that would happen when an adolescent is being abused. Perhaps they start failing grades in school, or they start having difficulty with friends or relationships in school. They may start to increase rebellious kind of activities, such as stealing or getting arrested or exhibiting violent behaviors themselves. They may act very seductively or promiscuous, maybe even participating in prostitution. And commonly, running away from home is a good sign that something is going on. So whatever we can do to help people stop this cascade of violence is our goal as nurses. Okay, so let's just move on real briefly to discuss elder abuse. I know you guys discussed this quite a bit in fundamentals 2 semesters ago, so we're just going to treat this as a bit of a review, okay? So elderly people are vulnerable populations just because of their poor health and perhaps poor mental status. Typically, depending on how disabling their conditions are, they can be dependent on their older children to take care of them, which puts them at risk. And what we know about caregivers is that if they're caring for somebody with a really severe physical or mental disability, that can be very stressful and taxing on the caregiver. And not intentionally, but the frustration may build. Now that we know about anger and aggression, if the stresses and the frustrations build, it can lead to abuse of the elderly person. What we know of a typical elderly victim is it more often occurs with females, elderly female victims over the age of 75, especially if they're living with a relative and if they're experiencing physical or mental impairment. So common types of elder abuse, we have the physical abuse, which is actually inflicting harm or striking or hitting the elderly person, or possibly like restraining them, using improper restraints or secluding them or locking them in a room, okay? Or maybe inappropriately giving medications such as tranquilizers. That would all be physical abuse. Psychological abuse would be that emotional abuse, verbal, maybe yelling, humiliating. There's nonverbal abuse also, such as the ignoring or isolating or terrorizing the person. And some examples might be denying the person their assistive device, like their wheelchair or their walker, or taking advantage of their confusion, or not reporting medical conditions that the person may be exhibiting, or not taking them to medical appointments, okay? We also have financial abuse. So oftentimes if people are mentally deemed incompetent because of dementia or Alzheimer's or whatever it may be, typically there is a power of attorney appointed. Usually the power of attorney is some family member. So financial abuse would be these powers of attorney that are taking advantage of their rights as the power of attorney and misusing the elderly person's finances, credit cards, taking their cash or using their checks, maybe forging the victim's signature or engaging in identity theft, things like that, okay? Neglect is another type of abuse, and that one is kind of obvious, but it's basically failure to fulfill their caretaking obligations to that elderly person. And we did mention this before, so not taking them to appointments, not reporting medical conditions and things like that. And I'm sure that you have heard in the news of some very severe cases in which the elderly person has actually died, and the family member continues to pretend like they're alive and receive their Social Security checks and use their credit cards and so on and so forth. Excuse me. Another example of neglect would be if you as the nurse were admitting an elderly person to the hospital and the person was incompetent, and this person had multiple severe bed sores to their body. This would be an indication of neglect. Obviously, this person has been left laying in bed, perhaps left in their own feces and urine, and developed these severe bed sores. So that would be an indication of neglect. So what do we do if we suspect that there may be some elder abuse going on? So if the individual is competent and can hold a conversation with us, we could interview the patient and try and find out what is going on. If the elderly person is not competent, we would want to be interviewing family members or people that are involved in that elderly person's life and watching for inconsistencies in stories. That would be a clue that something may be going on. Again, we want to make sure that we're documenting everything. All the data and information that we are receiving, we need to document. And again, use direct quotes from people so that we can show the discrepancies in the stories. because, you know, if this should be taken any further, we need to have that data to support the claim. We want to keep our questions simple and very clear, and we want to be assessing the physical body of the person and documenting any findings we have, so ecchymosis or stages of bruising such as yellowing or of old bruises and such, and where they're located on the body and size and things like that. So we want to assess the environment. What is the situation that the elderly person is living in? Who is the caretaker? Are they with them all the time? Do they take them to a day clinic? So assess the environment. Determine the person's competency. If the person is competent, we cannot report the abuse, okay? What we would want to do is consult a social worker at the hospital that we're working at, so that they can continue to investigate the situation. But we would not report at that time. However, if the elder person is deemed incompetent, this makes them vulnerable, doesn't it? And so we have to advocate for that elderly person who has some disability. So what we would want to do is to be discussing our findings, perhaps with the doctor or perhaps with the social worker, and between the team deciding if we needed to get social services involved or not, and get the ball rolling for a more uh, formal investigation of the situation. Okay, so it would be our responsibility to get the authorities involved if the person is deemed incompetent. This would end our lecture then on domestic and elder abuse.